leading doctor in the field of kidney transplantation in University Clinical Center in Vojvodina. Despite the significant improvement in the field of kidney transplantation, transplantation-induced autoimmunity, especially antibody-mediated rejection of kidney graft, is still one of the leading causes of graft loss. This reaction is measured by donor-specific antibodies. According to the time when they develop and the type of donor-specific antibodies, we can have three different types. First one is preform antibodies, which are caused by previous transplantation, transfusion, and pregnancies, and they can cause hyperacute rejection, accelerated ejection, and early acute antibody-mediated rejection. After the transplantation, patient can develop de novo or new donor-specific antibodies, which can cause late acute antibody-mediated rejection, chronic antibody-mediated rejection, and graft glomerulopathy. Benign form is clinically irrelevant because this third form doesn't cause graft loss. Those donor-specific antibodies can be detected, as we already heard from Dr. Kraljača, by three different procedures: complement-dependent cytotoxicity, flow cytometric cross-match, and solid phase assay. Also, we have new parameters which measure the reaction of the kidney recipient with the antigens of donors from the real pool of organ donors, and the only HLA incompatible transplantation is defined as positive CDC or FCM cross-match at the baseline. Recommendations are that we should use those new parameters to estimate the chance that a sensitized patient can be transplanted with a compatible donor without need to do any special desensitization procedure. When defining unacceptable mismatch in highly sensitized patient, one should always keep in mind that based on the weak antibody reactivities, we should always consider the light of prolonged waiting time and associated mortality and morbidity of our patients. In the future, we should pay attention and try to standardize single antigen bead assay, which is the most sensitive one, and pay attention of antibody epitopes rather than antigens of HLA system. We recommend that these new parameters should be used in highly sensitized patients. So when this need for kidney transplantation and for organs is developing and increasing over the time, except for the sensitization, new procedures are developed, and one of them is a kidney exchange program. This kidney exchange program make it possible for our patient who has a donor who is incompatible with the patient to get and to receive a kidney who is good and have better prognosis after the kidney transplantation. One of the simplest form is this paired donation, when we have two incompatible pairs and they just swap the donors and every recipient gets better organ. Second, also simple form is so-called closed loop, when we have 3 or even more patients, pairs who get organs from each other, and every recipient gets organ from donor of each pair. When this procedure is established in 1991 in South Korea, this procedure has enlarged the percentage of kidney transplantation from 2 to living donors transplantation from 2 to 15% in this country. In Europe, in 1999, in Switzerland, it was performed for the first time, and later in Dutch, 2004, and UK in 2007. But since it's sometimes complicated to get those pairs and close the loop, we tried to find some other ways, and one of them is non-directed altruistic donor who's giving an organ without any recipient. So this altruistic donor, or in second case, disease donor, starts domino reaction, and then we can have more living donor transplantation, and the last donor who doesn't have his pair will start the new chain. How can we also improve this method? One of ways is so-called list exchange. Sometimes the donor just give up during the process and doesn't want to donate the organ, or his organ is rejected due to medical conditions. Surgeons sometimes decline the operation. So if we don't want to have problems with that, we can do something called list exchange, that donor always give the organ first and his pair is waiting for his organ. Or new shame called chronological incompatibility, when donor gives the organ when it is needed and his recipient will be high on the list and get the organ when he or she needs it. Also, one of the ways to improve this kidney exchange program is including ABO or HLA incompatibility pairs in a kidney exchange program, and that is the way for a person to get better organ according to HLA mismatch or age or graft function and so on. So our recommendations are to increase and harmonize kidney exchange program with greater and standardized sharing of outcomes. This procedure has to be transparent and no data should be hidden from donors and recipients. We should try to include unspecified kidney donors if that's possible, and to include compatible pairs and disease donor in kidney exchange program, and sometimes entering in kidney exchange program is preferred over the sensitization program because of the better cost effectiveness analysis. As we already heard from Dr. Kraljača, desensitization program is expensive and some complications can occur during the procedure. So maybe this kidney exchange would be a better way to help our patient. This algorithm you also already seen, but it's not applicable for all our patients. It's not applicable in all our countries, but I think it's a good frame and something that we should all try to work on and to implement it in future. How to get kidney exchange program more effective? Well, we should always try to be transparent, objective, and responsible in donor-selected system. This system should always include possibly the best matching software, immunological testing, organization framework. Clinical leadership is very important. in terms of choice for immunological complex recipients, comparable recipient-donor pairs, and we should always try to seek for better HLA matching. Recipient and donor should be always aware of all the data. Centralized follow-up system is also very important, and continuous tries to improve and develop our system is also of the greatest importance. In order to improve our performances in kidney exchange program, we should always try to extend national pools of organs, allowing new modalities in kidney exchange, and of course to increase international cooperation. Thank you very much for your attention.